طيب، السلام عليكم مرة ثانية جميعا. ممتاز. طيب. You guys can see the screen now. اللي هو diabetes mellitus. حط الشات. ممتاز. طيب، المرة هذه we'll take it easy. I don't think there is a topic in medicine as important as the diabetes and the hypertension topics, because whenever you're gonna end up being سواء medicine, سواء surgery, سواء ICU, even if you're gonna go to public health, you're gonna not practice medicine, or you're gonna be an admin, or you're gonna be the minister of health, you're gonna encounter diabetes and hypertension. They are a very big topic. Every one of us should master what any doctor should master. I'm gonna ask you guys if you can mute yourself between time to time. I may ask you to unmute yourself and talk or discuss or raise question. But sometimes the noise in the background can bother some people, including myself. الله يعطيكم العافية. طيب. You guys went over details of diabetes, how the genetic disposition, as well as the environment factor eventually can lead to diabetes. So we wouldn't spend a lot of time. We'd like today to talk about a practical aspect of diabetes, especially when it comes to the management, investigation, and treatment. هذه الموبقات حقت diabetes, الافكت on insulin, isolate alpha cells, liver, brain, muscle, kidney, Davis tissue, just name it. Diabetes and hyperglycemia basically can affect all the body. Okay, just to get your attention, guys, about diabetes and the prevalence in Saudi Arabia. So basically, I'm still hearing some of the noise in the background. Can you guys mute yourself kindly? Right. A community-based study including 17,000 subjects, so it's a very large study, between 95 and 2000, examining age group between 30 to 70, so middle age group, during 5 years. هذا الله يعطيه العافية منصور النزهة. And they kept doing those kind of large cohorts in Saudi Arabia. So the overall prevalence of diabetes was 23%. That's meaning 1 in 4 of people in Saudi Arabia in that age group, they have diabetes. 1 in 4. This is very huge, okay? There is no difference between the males and females. And here, the most striking finding, in my view, that 27% they were unaware that they have diabetes. يعني 1 in 4 they have diabetes. 1 in 4 of those have diabetes, they are not aware of having diabetes. Just a striking finding, okay? Type 1 and type 2, you guys familiar with by now. There is other types, of course, of diabetes. Perhaps it's beyond the scope of today's lecture. but I thought talking about gestational diabetes would be very helpful. So gestation, from its name, it's happening during pregnancy. It's diagnosed in the second and the third trimester. So usually they're not going to happen in the first trimester. So as a rule of thumb, if you have a pregnant woman having elevation in their sugar to the level of diabetes in the first trimester, this is not gestational diabetes. This is whether type 1 or type 2, okay? And other type of diabetes, you can, guys, go over it. I'm pretty sure you went over it in a very details last year, but maturity onset diabetes of the young, it's been getting more attention recently. Basically, it's a genetic disease to have diabetes in a thin individual, usually in young adults. And don't forget steroid-induced diabetes, or even after organ implantation. Okay, so how to diagnose diabetes? I'm going to open the floor now and hear from you, whether in the mic or just type in the chat how to diagnose someone with diabetes. Lab test, be more specific. The more specific you are, the more accurate you are. Blood test. Okay, I'm getting some answers. So someone mentioning FBG, so I'm assuming fasting blood glucose. So FBG, okay. And then someone is saying A1C, so the hemoglobin A1C more than 7, okay. A1C of 6.5, which is, I think it's more accurate. Random blood glucose. Okay. Okay, I think you guys around the right answer. Fasting glucose, OGGT, which is, I'm gonna assume, oral glucose test. Random more than 200. Good. Okay, good. So focus, guys, when we talk about the cutoff, about a random one, okay? Especially that the random one accompanied by symptoms. So it's not all lab work. Sometimes you're gonna need some symptoms to suggest a state of hyperglycemia. So what are the symptoms, the classic symptoms of hyperglycemia? Polyuria, excellent. What else? Polydipsia, good. Which is, we're gonna talk in English nowadays. Polyphagia, okay, good. I think this is a really, really good classic symptoms of hyperglycemia. Allah yatakum al-afiyah. Okay, so the criteria for diagnosis, I think we already alluded to the biggies, which is the fasting blood glucose. The second is the 2 hours post-prandial or post-oral glucose test. And the third is the A1C. And the fourth would be symptoms with a random blood glucose. Okay, so we'll take it one by one. Okay. So fasting, which you should understand that fasting by all definition is basically defined as no caloric intake, okay, for at least 8 hours. So it's not 12 hours, it's just 8 hours. 12 hours, we use it for fasting for lipid profile, but it's not for diabetes. And fasting blood glucose is more than 126 milligram per deciliter, this is the American unit, or 7 millimole per deciliter. Okay, so this is the first one. This is the fasting one. The second is basically 2 hours post-prandial during an oral glucose tolerance test would be more than 200 milligram per deciliter American units, or per 11.1 millimole per deciliter. Okay, and to say this is actually glucose tolerance test, the WHO define it as glucose load containing equivalent to 75 gram of glucose dissolved in water. It's very, very irritated. يعني تخيل انك you drink a very high concentrated glucose. Sometimes actually people even vomiting the material. Okay. Do you need to know those cutoff? I think you have to. You don't have to memorize both units. I think if you memorize one unit, it would be useful. The third is the famous hemoglobin A1C, more than 6.5%. Okay. And the fourth is basically patient with classic symptoms of hyperglycemia or in hyperglycemia crisis meaning DKA or hyperosmolar states, hyperosmolar coma state, and the random blood glucose is more than 200 milligram per deciliter, or in the international unit more than 11.1 millimole. And notice this is actually the fourth cutoff is resembling a post-prandial. Okay. Any question about the diagnosis? Someone is asking diagnosis of diabetes at lab, not from symptoms. Is this a statement or you change your mind now? Whoever asking about the diagnosis of diabetes at lab, not from symptoms, statement. Okay, so we just went over a diagnosis and we clearly mentioned the fourth one would be classic symptoms of hyperglycemia and a random blood glucose over 200. So there might be a symptoms playing a factor here. And this is why I ask actually this question. Is this clear, guys? Especially for the one talked about the point. Good. Okay, so next, we have a state. We call it pre-diabetes. And from its name, pre-diabetes meaning that they are prone to have diabetes. Not only that, pre-diabetes by itself, it's actually by itself can be pathology, okay? And it have a different cutoff. You would expect it to be lower than the diabetes. So when it comes to the fasting, it's more than 100 milligram per deciliter. It's more than basically 5.6 millimole, all the way to 125, which is 6.9. Okay, just to go over fasting again here, you notice here the cutoff is 7, the cutoff here is 6.9. At 125, 126. So it's actually almost an exact point between the two. Is this relevant? I think it's relevant for you guys to understand the spectrum. So if you have someone, their fasting glucose is actually, let's say, 124. So they are very close to be actually diabetic. It's a little bit different in someone, they have a fasting blood glucose of 100, which is really a pre-diabetes, okay? So you would approach them a little bit differently. The one very close to diabetes, you're gonna be aggressive when it comes to the intervention, aggressive when it comes to repeating the test in a 3 to 6 months because they're going to be diabetic probably soon, comparing to someone just entering the pre-diabetes phase. The second cutoff is the 2 hours postprandial with 75 oral test is 140, 7.8 to 11. It's easy just to remember one of the two numbers instead of remembering them both. And the third is A1C of 5.7 to 6.4%. Okay, so this is actually the range to call someone having a pre-diabetes. Any question, guys? Okay. Who to screen for diabetes? It's a long list. In Saudi Arabia, I believe everyone should be screened because a lot of us already have a first-degree relative with diabetes. Certain ethnicity, especially African American, Native American, Asian, Pacific Islander, they are at risk. History of cerebrovascular disease with a stroke or MI, hypertension, history of dyslipidemia with a low HDL, the good cholesterol, or elevated triglyceride, women with polycystic ovarian syndrome, physical inactivity, which is a lot of people falling into this category, clinical condition associated with insulin resistance like obesity, acanthosis nigricans. Patient with pre-diabetes, they should be tested at least yearly for diabetes. Women diagnosed with GDM, gestational diabetes, and pregnancy, they should have their diabetes checked every 3 years. All patients at age of 45 and above, they should be screened, as well as if the tests are normal, minimum it should be repeated every 3 years, but more frequently if otherwise indicated. Okay, so how to prevent or delay type 2 diabetes? Okay, this is very important because على قولة العرب الأولين درهم وقاية خير من قنطار علاج. So we need to monitor them, especially those people they are in a pre-diabetes stage. Okay. Also, those people obese or overweight, we would like them to lose at least 7% of their initial body weight. Also, we'd like them to exercise, and exercise mean brisk walking, مشي على السريع, at least 150 minutes per week. يعني تقريبا you can do it 50 minutes 3 times a week. You can do it, for example, if you're going to do it 7 times a week, يعني daily, you can do it, for example, 30 minutes a day. But the total would be 150 minutes per week. Okay, you can also use some of the technology assistance, those especially يعني reaching a diabetes, they can check their diabetes regularly. Sometimes even people will prefer to put a continuous monitoring for their glucose. It's an extreme, but it's an option. Metformin. So we use metformin for those people in pre-diabetes, especially if they are actually obese, or they are young, less than 60 years old, or if they have a history of GDM, because we know those people, they will be a diabetic, most likely. If you are young, that's meaning more time, meaning more chances of being diabetic. If you are obese, metformin will help you to lose weight and will help you to prevent and delay being diabetic. Okay? And of course, we should test for other modifiable risk factor for cardiovascular disease. So what are the modifiable risk factor for cardiovascular disease, guys? Give us 4 or 5 modifiable risk factor for cardiovascular disease. Good. Stop smoking. Excellent. What else? Oh, smoking cessation. Obesity, I like that. So try to come up with ways to reduce the weight. Good. What else? Exercise. So that's the treatments for sedentary life. Control the level of cholesterol. Good. Diet. I think that's reasonable. Now it's gaining momentum. The Mediterranean diets, and the diet and the exercise both fall into the lifestyle modification and hypertension. That's excellent, guys. That's really, really, really good modifiable risk factor for cardiovascular disease. Good. Okay. When it comes to managing patient with diabetes, we really need a comprehensive evaluation and assessment. And what do we mean by that? Okay. So it's a cycle. Okay. We start with patient characteristics. So we see their lifestyle. We see their other comorbidities. We see their clinical characteristics. How old are they? What their age? What their current weight? Okay. We try to find motivation for them to exercise more and to identify those with depression so we can treat the depression. Hopefully that will help them taking their medication as well as doing more exercise, as well as addressing the culture and the socioeconomic context, okay? What else? Well, then now we are talking about specific factors that impact the choice of treatment. So what their individual hemoglobin A1C target? Not all people will have the same target. What's the impact on weight and hypoglycemia? People already overweight or already obese, you don't want to give them treatments, they will cause them to gain more weight, okay? Those people at risk of hypoglycemia, you don't want to give them agents are more frequent to cause hypoglycemia. We're going to talk about that shortly. Side effect of the medication, complexity of the regimen, who's going to follow them? What's the cost if they're going to pay for the medication out of their pocket? And then we talk about shared decision making, okay? Involving a patient, take the informed consent, talk to their family. This is all very relevant. If someone living by themselves, you don't want them to have hypoglycemia unwitnessed and they may die from that, comparing to someone already have, for example, a nurse dealing with them at home or at the long-term facility. And then try to come up with a management plan that's following the SMART goal. SMART being specific, measurable, achievable, realistic, and time limited, okay? So this is what we call it, the SMART goal and management plan. Okay, so furthermore, in the comprehensive medical evaluation, first we have to confirm the diagnosis and classify the diabetes. Is this type 1, type 2, other types? Know what's the diabetes complication and potential comorbid condition. We talked about hypertension, smoking, obesity, dyslipidemia. So you have to evaluate them for that. Review previous treatment. If they've been on other treatment, you have to go over it and see whether it's worked with them. If they develop side effects and they stop them by themselves, try to ask why and whether it's actually still a reasonable choice for them. Try to engage the patient in the formulation of care. Don't forget that the diabetes, it's a chronic disease, and we need the patient, which is the stakeholder, to be with us and making the decision. Okay, so this is, we already talked about it in the comprehensive model. Some of them you will do them only in the initial visit, for example, what their age, previous treatment, frequency of previous hospitalization. Others, you're going to do it in each follow-up. For example, if they've been visited their specialists, eye specialists, kidney specialists, foot specialists, as well as annual visit. They have to check their teeth annually. They have to have a dilated eye exam by ophthalmologist yearly, as well as visiting their specialist at least annually. Okay. This is just to complete the social history, medication, and vaccination using the technology, and also screening for psychosocial conditions, especially depression and anxiety, self-monitoring, hypoglycemia. In each visit, you have to ask them about hypoglycemia symptoms and whether they actually know what's hypoglycemia symptoms and what to do if they have hypoglycemia, and then pregnancy planning for childbearing women. Physical examination, it's a long list, but in each visit, we have to check their height, their weight, their BMI, their blood pressure, whether it's actually within the targets, palpating their thyroid, because don't forget, when you have diabetes, you are prone to have thyroid disease, hypothyroidism in particular, examining the skin, checking their visual screening. You guys can see this is labor extensive, and this is why we need more diabetes clinic to take care of our patient with diabetes. This is a huge burden in any health system, including ours. When it comes to the laboratory testing, the A1C every 3 months, lipid profile, liver enzymes, urine albumin to creatinine ratio, creatinine in the blood, TSH, especially in type 1, vitamin B12, especially if they are in metformin, as well as the potassium if they are in ACE or ARBs or in diuretics. Assessment and plan, setting the goal, especially for A1C and their blood pressure, as well as assessing their cardiovascular and how to optimize their cardiovascular risk factor and try to reverse irreversible causes. And then when we talked about a therapeutic treatment, lifestyle management, diet and exercise, pharmacological treatment, referring to specialists, and how to monitor their glucose and review their insulin delivery devices and make sure that they know how to use it. Okay, assessment for hypoglycemia. So first, what are the hypoglycemia symptoms, guys? Welcome. We'll take our time, guys. So what are the hypoglycemia symptoms? Good, good. Wallahi, mashallah alaykum. Excellent. Okay, so we'll go over it. Coma, yeah, they can be in a coma. Dizziness, yes. Heavy tongue, yes. It actually can resemble, it's one of the mimic for stroke. Dizziness, sweating, excellent, yes. Exhaustion, yes. Polyphagia, I think it's a hyperglycemia symptoms rather than hypoglycemia, but good thought. Palpitation, excellent. Coma, pallor, loss of consciousness, palpitation. Excellent. Whoever said increased sympathetic activity, that's an excellent, like lumping a lot of symptoms, including palpitation, sweating, tremor, and blurred vision. Excellent. So now let's talk about who is at risk of hypoglycemia, okay? And let me know if any of those risk factor doesn't make sense to you, okay? So First, use of insulin. Insulin is a medication, definitely can cause hypoglycemia, or insulin secretive. Like insulin, the medication can release more insulin, like sulfonylurea or meglitinides. Okay, that I think makes sense. When you have more insulin, you are prone to have hypoglycemia. Impaired kidney or hepatic function, because a lot of those medications can be metabolized by liver or kidney. So when you have dysfunction of kidney or liver, you may end up having hypoglycemia. How about this? Longer duration of diabetes, because the more longer duration of diabetes, it's basically you are more prone to have hypoglycemia because your glucose controlling has become more difficult. Your insulin, your original insulin, and someone with a longer duration of diabetes, they're not going to have a lot of insulin, which make controlling the blood sugar really difficult. Frailty and elder age, of course, sometimes they are not going to express the symptoms of hypoglycemia. They're not going to have an access to check their blood sugar by themselves. Cognitive impairment is the same. They're not going to be able to express the symptoms of hypoglycemia. Another big one, impaired in the counter-regulatory response. So counter-regulatory response like glucagon. So people with actually liver disease, they will have this problem. Hypoglycemia unawareness. People with prolonged history of hypoglycemia, they sometimes not going to be early aware of the hypoglycemia symptoms. They may reach a coma stage without having the symptoms of hypoglycemia. Physical or intellectual disability that may impair behavior response. That's meaning inability to go and access the blood glucose checking machine, inability to go and actually taking food to prevent bad hypoglycemia. Alcohol use, it's a big one, and polypharmacy, especially ACE or ARBs, or non-selective beta blocker, because if you have a non-selective beta blocker on board, that may actually block the sympathetic activity, so you're not going to have the symptoms early on. Any of those risk is not clear to you guys. It's a long list, but it's an important list actually. Any question, guys, about this list of risk factor for hypoglycemia? اسألوا قبل أن تسألوا. Okay, so let's move on if you guys have no question. Okay. What are the sympathetic? Sympathetic, it's not a side effect from the medication. It's actually a response from the body for the hypoglycemia. So it's basically, you have a lot of adrenergic effects. So you will have some tremor, you will have some sweating, you will have some hungry feeling, you will have some blurred vision. So all of this within the umbrella of sympathetic activity. Good question. Any other question? And unfortunately, when you have beta blocker on board for any other reason, for example, you have also heart disease, this effect may be blocked temporarily. So you may reach a coma state without passing the sympathetic activity phase. Okay, so referral. So a lot of professionals going to be involved in the diabetic care, and this is part of why the diabetes is important. If you are going to be an ophthalmologist, you're going to see tons of diabetic patient. If you are a family doctor, you're going to see tons of diabetic patient. If you are actually a family doctor, you're going to see tons of diabetic patient. If you are actually an obstetrician, you're going to see ton of diabetic. Also, if you are a dietitian, you're going to see a lot of diabetics seeking medical attention. What's the best diet for me? Even if you're going to be a dentist, again, a lot of people, we're talking about 1 in 4. يعني من كل 4 there is 1 diabetic individual, and the numbers are rising. They are not actually being suppressed recently. Okay. So let's talk about the glycemic target, because we agree early on that not all individuals, they will have the same target. Okay. To set the initial target of A1C, of course, the A1C should be checked at least twice a year. Ideally, it would be 4 times a year, every 3 months, because the A1C is the average glucose level in the blood over the last 3 months. ده يعني خلينا نقول general rule for the target A1C in non-pregnant adult is less than 7%. So this is the general rule, okay? There's going to be a lot of exception, but this is the general rule, is less than 7%. Who are the exception? Well, if you have someone young and they can achieve an A1C level less than 6.5% without significant hypoglycemia and without other side effects from the medication, it would be preferred. And an example of this, if you have someone in their 30s or in their 40s, highly educated, aware about the side effects of medication, they can monitor their blood glucose frequently, and they can avoid going into hypoglycemia, yes, we should target more strict A1C, less than 6.5. I would say even sometimes even tighter, okay? But who are we gonna be more liberal when it's come to the A1C target? We're talking about less than 8%. Those people with frequent hypoglycemia, okay? People with limited life expectancy, like people we know that they're gonna die in 1 or 2 years. We don't want them to suffer from hypoglycemia. Those people with advanced micro or macrovascular complication, because the risk of hypoglycemia sometimes is overweighing the benefit of controlling the blood glucose. Because don't forget, we are going from hyperglycemia to hypoglycemia. Hypoglycemia, we know it is as bad as hyperglycemia. It's actually sometimes even worse, especially with people with coronary artery disease. Okay, so this is just the target. I think having at least remembering the target of A1C, I think it would be reasonable. But remember, sometimes people, they're not going to have an access to A1C, and believe me, even in Saudi Arabia, some of the rural area, we don't have an access to a lab doing an A1C, so we'll end up relying on the echo check, the glucose check. Okay. So what is the hypoglycemia? We talked about the symptoms. It's basically measurable glucose concentration less than 3.9 millimole, okay, or less than 17, the American unit. This is level number 1. Level number 2 is basically when you have less than 3, and this is usually accompanied by what we call it neuroglycopenic symptoms. Neuroglycopenic symptoms, what we basically mentioned early on about dizziness, hungriness feeling, the decreased level of consciousness. This is all considered as the effect of glucose inside the CNS. Okay, it can be actually severe to the level that they can have an altered mental state. It actually can resemble the stroke. The hypoglycemia is one of the mimic for stroke. Do you guys have to remember all the levels? No, absolutely not. If you remember that what are the symptoms of hypoglycemia? Hypoglycemia being the glucose concentration less than 3.9, and understand the concept of neuroglycopenic symptoms, I think that would be more than enough. And don't forget, how do we treat hypoglycemia? Well, we ask people, sorry, I'm jumping. Yeah, so how to treat hypoglycemia? Well, first, we try to give them some glucose, especially glucose containing juice, for example. And this is why we ask people with diabetes to have some glucose containing whether snack or juices, يعني juice box nearby. So whenever they're having a hypoglycemia symptoms, or they have an aqua check, they have a low glucose level, they should consume the glucose, and then 15 minutes they will have to recheck the level. If they're still having hypoglycemia, that's another cycle of glucose containing material, whether food or juice, should be done. If they're still having hypoglycemia, they should seek medical attention, as well as they may use the glucagon. The glucagon actually should be prescribed for all individuals at risk of hypoglycemia. It's to counter attack the insulin and to improve their glucose. Glucagon is not limited to be used by healthcare profession. They actually can be used by a patient and their relative, and it certainly can save some lives. Okay. Okay. Any question about hypoglycemia, guys? It's a very important topic. Whenever we talk about diabetes and diabetes treatment, I think we should talk about hypoglycemia, how to recognize it, how to manage it, how to avoid it, who are the people at risk of having hypoglycemia. Okay. Cardiovascular disease and risk management. Again, when we talk about diabetes and reason of death, of course, cardiovascular going to be on top of that. Okay, so we always have to check the blood pressure in an individual with diabetes, and if they found to have a blood pressure more than 140 or 90, the diastolic, we should repeat. And if they're still having persisting elevated blood pressure, they actually should be diagnosed with hypertension and start on medication. You guys probably, what are the drug of choice of hypertension in people with diabetes? We have a lot of family, a lot of groups of antihypertensive medication. Which one is preferred for people with both diabetes and hypertension? Good. Yes. So ACE and ARBs. ACE and ARBs are the preferred choice. Yeah. So captopril is one of them. So ACE or ARBs are the preferred choice. Thiazide, it's not the first choice. In fact, there is some evidence in the literature suggesting that maybe thiazide in people with no diabetes, they only have hypertension, it may actually increase their risk of having or developing hypertension, okay? Okay, so people asymptomatic, we screen them for hypertension. We talked about that, but we don't have to screen them for coronary artery disease. That's meaning we don't have to do, for example, angiogram to see if they have coronary artery disease, but we should optimize all their risk factor. And of course, if they have disease suggesting of coronary artery disease, like let's say angina, dyspnea, unexplained dyspnea, chest pain, of course, they will have to be investigated for coronary artery disease. When it comes to the antiplatelet, there is a lot of discussion in the medical field about the aspirin when it comes to the primary prevention. So remember, primary prevention meaning this individual never has actually coronary artery disease. So we are giving them to prevent the first hit, okay? So there is some people advocate to give aspirin as a primary prevention in people with type 1 or type 2 at increased cardiovascular risk. That's meaning if they are age more than 50, who have at least an additional risk factor for coronary artery disease like family history, hypertension, smoking, dyslipidemia, or albuminuria. If they have low risk, usually people wouldn't recommend aspirin for primary prevention. When it comes to the secondary prevention, you guys see that all people with diabetes or even without diabetes, if they have cardiovascular illness, they should be in aspirin. A is the highest level of evidence. So especially if they are diabetic, they should be actually on aspirin. If they are allergic to aspirin, other antiplatelet agents like Plavix, clopidogrel would be substitutes. Okay. This is again, when it comes to the lipid, so we always like to optimize all of their risk factor, okay? So when it comes to the lipid, we have a different cutoff. If you are diabetic, we would like your LDL to be actually further controlled comparing to someone doesn't have diabetes. Those are the cutoff. So if you are less than 40, but your LDL is less than 70, I think this is equivalent to 2.6 millimole in the other unit. You need to be on lipid lowering agent. The idea, guys, if you have diabetes, your LDL target will be different. And again, if you have diabetes, your blood pressure target would be different, okay? So we are aggressive treating people with diabetes, aggressive treating their lipidemia, dyslipidemia, as well as their hypertension. What are the drug of choice? Usually we use high or moderate intensity statin like atorvastatin or rosuvastatin. If someone develops some side effect or they are just above the target, other choices would be reasonable. You can use lower intensity or lower doses of the atorvastatin and rosuvastatin. Okay, this is just a combination of statin and fibrate if you didn't actually achieve the LDL target. Okay. Any question, guys, about the macrovascular complication, the cardiovascular complication? I want you guys to ask questions. Yeah, please go ahead. Someone has asked, at which age we give all medication? I don't understand the question. Is it about the lipid lowering agents or aspirin? It's easy to remember the LDL target, okay? Although the statin in general, if you have diabetes and you're above 55, in general, it would be indicated. But we actually have targets for them for when it comes to the LDL. We are looking for something less than 70, and which is the millimole, it's 2.6. So remember one of them. When it comes to the hypertension, it's another story, okay? So the hypertension, the cutoff is more than 140 or more than 90. And once you diagnose them with hypertension, you'll have to target a blood pressure less than 130 and less than 80, okay? But don't forget, there is another indication for antihypertension medication, the ACE or ARBs, which is the proteinuria. So people with proteinuria, even if they don't have hypertension, we may end up using ACE or ARBs for the proteinuria. Good question. Any other question? Okay, so I'm assuming there is no question. Okay, we'll move on. Okay, so when it comes to the microvascular complication, we talk about several ones. Kidney is among the top, so we check their proteinuria. We can assess that by checking the urine albumin. This can be as a spots, urinary albumin to creatinine ratio, but we also can do 24 hours. But it's just the spot urinary albumin to creatinine is a very convenience for patient. Okay, so the key when it comes to the kidney disease as well as with the retinopathy is to optimize the glycemic control. This is why we would like their A1C to be as low as possible, like less than 7% if it is possible, as well as controlling the other risk factor like blood pressure and serum lipid level. When to screen them? Yani, this is good to go over it, but I think really this is for specialized clinic. But I'd like you just to understand the concept behind it, that really when you have diabetes for more than 5 years, you should start, we're talking about type 2, huh? When you have type 1 more than 5 years, you will have to check your microvascular complication. When it comes to the type 2, we check it at the time of diagnosis. And the reason, guys, is the following. We talked about 1 in 4, they are unaware about their diabetes diagnosis. So maybe they actually sometimes they already have the diabetes for 5 years without knowing, and now they show up in the clinic. So we assume that it's been going on for a while, and we have to assume that they actually already may have some microvascular complication. Is this clear, guys? This is very important point. يعني connecting prevalence to the screening. Okay, I will repeat. حنا قلنا, we said إنه 1 in 4 people, this is in Saudi Arabia, 1 in 4 people are having diabetes without knowing it. They don't know that they have diabetes, okay? So when they get diagnosed with diabetes, possibly they've been actually have diabetes for more than 5 years. So we wouldn't wait for another 5 years before checking their microvascular complication. We assume that they actually may have diabetes for a long time, and we check them for microvascular complication, in particular, checking their eyes, okay? Okay. Talking about telemedicine. The third microvascular, so we already talked about kidney, eyes. The third would be neuropathy, okay, which is basically peripheral neuropathy, can start to happen after 5 years of diagnosis of type 1. How do we check that? I don't know if you guys actually ever have the small fiber function. Basically, we can actually check the sensation. We have what we call it in the clinic monofilament testing. So it's basically it's a single monofilament, and we put it at the bottom of the foot and ask for the sensation. This can be done actually in the clinic to check whether this individual reached and developed neuropathy, and usually it's going to happen in the longest nerve, which is happen to be the one in the leg. Okay, and don't forget about the foot care. So they will have to have a comfort shoes. They will have to check their shoes before actually wearing them. لأنهم some of them, they don't have sensation for their foot. So if there is مثلا, for example, a stone or a toy, they actually may wear a shoes and it causes basically a pressure, and they are not aware about the pressure, and eventually can lead to an ulcer and subsequently to basically an infection, or what we call it diabetic foot. So always examine the foot for your diabetic patient, looking for, of course, any deformity, do the neurological assessment, and try to ensure that they have a good nail hygiene, okay? And of course, we'll have to check the vascular assessment, as they are prone to have a peripheral vascular disease, okay? طيب, any question, guys, before we go to the bulk of this lecture, which is the diabetic management? And if you guys want to take a break, I'm more than happy to take a break. Actually, let's take 10 minutes break. It's a long lecture, so let's take 10 minutes break. So we'll start at, let's go. أبيكم مركزين معي. 45, okay. 10 دقائق, I think it's a good break. أبيكم مركزين معانا.